Hello everyone, my name is Kendall Davis, and today I will be teaching you a little bit about traumatic brain injuries. We will go over how the brain plays major roles in human functions, signs and symptoms of problems related to each brain area, and a few accommodations that can help students with this disability thrive in the classroom. So what exactly is a TBI? The definition of this disability from the federal government is that traumatic brain injury means an acquired injury to the brain caused by an external physical force, resulting in total or partial functional disability or psychosocial impairment, or both, that adversely affects a child's educational performance. Traumatic brain injury applies to open or closed head injuries, resulting in impairments in one or more areas, such as cognition, language, memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual, and motor abilities, psychosocial behavior, functions, information processing, and speech. The term does not apply to brain injuries that are congenital or degenerative, or to brain injuries induced by birth trauma. Also note that inherited genetic conditions that cause longitudinal damage to the brain are not considered traumatic brain injuries, because a TBI is a result of physical force, usually occurring because of some type of tragic accident that was usually preventable. The cerebellum is a structure of the brain located toward the back and the bottom of the skull, protected by the skull itself as well as the vertebrae at the top of the spine called the atlas and the axis. In this diagram, it is highlighted in pink. Primary functions of the structure include voluntary motor movement, balance, equilibrium, and muscle tone. An interesting fact is that the inner ear also plays a large role in a person's equilibrium. Semicircular canals near the cochlea are filled with fluids that sense a person's place in space, similarly to how the cerebellum does by helping people stay balanced. When the cerebellum is injured, many problems can occur. Symptoms of damage to the cerebellum include slow movements, asnergia, which is a loss of motor movement coordination, dysmetria, which is an issue with perceiving depth, adiadochokinesia, which is not being able to switch between various movements, intention tremor, which is displaying a tremor during movement, ataxic gait, which is staggered walking, falling, hypotonia, which means weak muscle tone, ataxic dysarthria, which is slurring of the speech, and nystagmus, which is unusual eye movements. The cerebellum is important to many motor functions that affect so many areas of a person's life, meaning that a person with severe injury to this region would most likely require assistance doing many daily tasks involving movement. The frontal lobe is the largest section of brain tissue separated into right and left lobes that are created by uniquely folded asymmetric convolutions. It is prone to impact injuries because it sits right behind the forehead and the skull. Although the skull is thick and durable, impact upon the frontal area can jostle the brain and cause mild, moderate, or severe damage. In this diagram, it is highlighted in purple. The frontal lobe has many complex and interwoven functions that help each person develop into a unique individual. A few of these functions include emotions, personality, motor movements, problem solving, spontaneity, memory, and language. There are many signs to look for if frontal lobe injury is suspected. Symptoms involving cognition include a change in social behavior and socialization patterns, abnormal sexual behaviors, difficulty with solving problems, decreased attention, lower memory capacity in the working memory, and problems with processing information provided by the environment. Symptoms involving motor movements include problems with spatial orientation, decreased accuracy when performing fine movements, decreased strength in the upper limbs, little facial expression, and Broca's aphasia, which is difficulty with creating speech. Tests that can help judge the abilities of the frontal lobe include response inhibition tests, motor skills tests, and language tests. In order to observe a person's overall change in social and emotional behavior, however, a doctor would need to closely monitor the patient for a longer period of time because the change in these functions are less easily observed than the ones observed by simple tests like motor skills tests. A person with an injury to this area can have a variety of issues that come along with it, and the need for assistance varies upon each individual case. The occipital lobe is located in the back of the skull right above the cerebellum, and it is similarly protected by the base of the skull the way the cerebellum is. In this diagram, it is highlighted in green. Primary functions of the occipital lobe include visual processing, visual spatial processing, which affects depth perception, and it also discriminates between moving and still objects, as well as uses information collected by the rods and cones in the eye and makes sense of them to help people perceive color. An interesting fact is that the only color receptors that people have are blue, red, and green. It is ironic because many people think that color receptors should be blue, red, and yellow, which are the primary colors. All other colors that people see are simply combinations of these three, and the rods and cones perceive various colors in different arrangements to allow humans to see every shade and hue as light reflects off objects in bright or dim light. Also, it is interesting to note that when something is seen as red, it is actually every other color besides red. The object absorbs every other color in the light spectrum and only reflects the red light waves to the human eye. Also, red light waves are the highest energy waves, green falls somewhere in the middle, and blue is the lowest energy. A symptom indicating damage to the occipital lobe is loss of vision with field cuts in the eyes, meaning that vision can be impaired peripherally or in another symmetrical pattern affecting each of the eyes similarly. The damage here is not to the eyes themselves, but the problem happens because the occipital lobe is having trouble fully processing the visual information sent to it, and therefore it cannot comprehend all the external stimuli being sent to it through the optic nerves connected to each eye. Other symptoms include hallucinations, which occur without any stimuli, and illusions, which is a distorted perception of what is actually being seen. People with problems in this brain region are affected mostly by their inability to use their sense of sight properly, which is thankfully a very adaptable disability with modern assistive technologies. The parietal lobe is located in the top and back of the head and is distinguished by two sublobes, the right and the left. In this diagram it is highlighted in red. The two lobes work in different ways but come together to compile sensory input into one single cognition. Primary functions of the parietal lobe include integrating sensory input, perceiving sensation, perception, and spatial awareness. There are many signs that could indicate damage to this area, as this lobe is responsible for bringing sensory input together and making sense of it for the person. Symptoms of damage to this area include a person showing abnormal body image awareness, not understanding their place in space, displaying confusion between right and left, agraphia, which is difficulty writing, acalicula, which is trouble with math, aphasia, which is speech issues, agnosia, which is not perceiving objects in the right way, contralateral neglect, which is not using a part of the body or some of the space in a room, constructional apraxia, which is not being able to build things, and anosognosia, which means the person is in denial of their deficits, difficulty drawing, ocular apraxia, which means loss of control where the person is looking, simultanagnosia, which is not being able to integrate the input provided visually, optic ataxia, which is not accurately reaching for objects when looking at them, and changes in verbal or nonverbal memory or personality, but this usually only occurs when the damage is near either of the temporal lobes. Tests for apraxia and for somatosensory skills are ways in which a person can be tested for damage to this area. A person with damage to their parietal lobe will most likely exhibit issues with understanding the world around them, and may require lower level sensory input that their brain will be able to process and compile. The brainstem is located at the base of the brain and is the dense connected bundle of nerve fibers that come together to eventually form the spinal cord. The end of the brainstem passes through the foramen magnum, which is essentially the big hole at the bottom of the skull. In this diagram it is highlighted in orange. The brainstem normally aids people in their attentional abilities, regular arousal processes, and creates the sense of consciousness. All of the somatic sensory input that is perceived by each nerve ending in the body eventually makes its way up to the brain through the brainstem. Symptoms of brainstem damage include an inability to pay attention, not being aroused by stimuli that was once exciting, frequent loss of consciousness, or a feeling of not being all there. This area is subject to damage because of the spiny protrusions of the cervical vertebrae that can pinch the nerves and inhibit messages being sent between them. A person with damage to their brainstem may need stability support for their neck as to avoid any further damage by the surrounding joints. The temporal lobes are located on either side of the head behind the ears. In this diagram, they are highlighted in blue. Like the parietal lobe, this area is also a major center for organizing sensory input. It also categorizes objects, aids in memory, and formulates the personality. The many symptoms of temporal lobe damage are problems with sensing and perceiving auditory stimuli, trouble filtering out unwanted noises or sights to maintain focus, experiencing illusions or hallucinations with visual perception, impaired organization and categorization of verbal material, trouble understanding language, loss of long-term memory, different personality, changes in sexual behavior, decreased recall ability, and decreased tonal ability, which affects musical skills. Tests for visual and verbal memory are usually done to assess potential damage to the temporal lobes. A person with an injury to this area is most likely going to have speech problems that stem from the inability to organize the auditory input, which can be helped by doing activities that help the person learn how to group things into small categories. So how can educators help students with TBIs in their own classroom? When a student has trouble with the executive function of organization, the teacher can help them by creating task analysis charts to help the student organize their thoughts and actions. An example of this would be to give the student clear, step-by-step instructions that they can check off, so they can see the progress they have made and feel accomplished. When a student has trouble with attention and concentration, the teacher can help them refocus and tune out distractions by reducing the auditory and visual stimuli in the room. An example of this would be to seat the child near the teacher's desk, rather than by the doorway, the window, or the back of the room. They can reduce extra noises and also not clutter up the walls with too many distracting things. When a student has trouble with visual processing, the teacher can help them by allowing extra time on reading assignments, teaching them to track their place on the page, and provide them books on tape to listen to. An example of this strategy would be to let the students stay late to finish assignments and allowing them to highlight information in a book with the help of an outline provided by the teacher. When a student has trouble with communication, the teacher can help them by changing the way their tests are presented and design them so they are based on recognition instead of retrieval. An accommodation of this would be to provide multiple choices instead of fill in the blanks and word banks that are used to match up the question with the answer. When a student has trouble with emotional expression, the teacher can help them by establishing trust and a sense of security in the classroom environment. An example of this would be to have open communication with each student, explicitly teaching lessons about social skills in class, and allowing students to practice positive social interactions among their classmates. When a student has trouble with behavioral issues, the teacher can help them by redirecting their anger or upset feelings towards something more positive. An example of helping a student with behavioral issues would include providing visual cues, maintaining consistency in directions and communication, and chunking down tasks to reduce frustration and stress. Thank you for watching my traumatic brain injury digital story, and I hope you learned a little bit about the functions of the brain, signs and symptoms of injury to each area, and accommodations that might help a student in your own classroom.